Okay, today we discuss hypertensive emergency and hypertensive urgency. In hypertensive emergency, patient present to you with high blood pressure more than 180 by 120 mmHg with in-organ damage. In hypertensive urgency, patient present to you with high blood pressure but no in-organ damage, and mostly patients are asymptomatic. In hypertensive emergency, patients are symptomatic. In hypertensive urgency, the aim is to control reduction of the blood pressure. Reduce blood pressure over days, not in hours, because sudden drop in blood pressure can cause stroke and other serious complications due to hypoperfusion. So in hypertensive emergency, if the patient present to you with high blood pressure, in-organ damage, how you find patient develop in-organ damage? We say patient are symptomatic if the patient develop headache, irritability, confusion, alter mental status with high blood pressure, hypertensive encephalopathy, high blood pressure, and patient develop hematuria, proteinuria, and AKI, deranged crete in urine, blood in urine, protein in urine, hypertension, nephropathy. If the patient have high blood pressure and develop chest pain radiating to left shoulder and arm, you investigate, you do ECG, you do cardiac marker, deranged cardiac marker, and changes in ECG, patient develop MI. On examination, you check vitals and physical examination. Vitals, you check blood pressure, saturation, heart rate, respiratory rate, temperature. And physical examination, you check JACLET. JACLET means J, jaundice, A, anemia, C, cyanosis, chylonychia, leukonychia, edema, and thyroid examination. You take the history of drugs, MAOI, rest and stop of clinidine, cocaine, and amphetamine. You admit the patient in ICU, CCU. In first hours, you reduce the blood pressure, you reduce the mean arterial pressure up to 25%, not more than 25%. If you reduce blood pressure more than 25%, you face serious complications like due to decreased perfusion. If perfusion decrease, then coronary ischemia, cerebral ischemia, retinal ischemia, and other complications, serious complication occurs. So in first hour, you decrease blood pressure, you decrease the mean arterial pressure up to 25%, and next 2 to 6 hour you reduce blood pressure you up to 160 by 100 mmHg, and you reduce to baseline in 24 to 48 hour. Must remember, give injection labetalol come in strength 50 mg or 10 ml. You give 4 ml 20 mg slowly over 2 minutes. Wait for 15 minutes. If you check the blood pressure, if still blood pressure high, use 4 to 8 ml every 10 minutes. We say reduce blood pressure in first hour, 25% mean arterial pressure. How you calculate mean arterial pressure? Mean arterial pressure, pressure in artery in one cardiac cycle. Normal mean arterial pressure is 70 to 100. Mean arterial pressure per molar 2 and 2. Diastolic blood pressure plus systolic blood pressure divided by 3. For example, if the patient have blood pressure, systolic blood pressure 210 and diastolic pressure 110, so mean arterial pressure of the patient is 2, diastolic blood pressure 110 plus systolic blood pressure 210 divided by 3. So mean arterial pressure come 143. We calculate the 25% because we reduce 25% in first hour of the blood pressure. So to calculate 25% of 143, 25% is equal to 25 divided by 100 is equal to 0.25. 0.25 multiplied by 143, 143 is equal to 35.7. So 25% of 143 is 35.7. 143 minus 35.7. So mean arterial pressure is equal to 107. In some special cases, rapid lowering of systolic blood pressure, usually to 140 mmHg, which is in first hour. In severe preeclampsia or eclampsia, aortic dissection, and pheochromocytoma. In these special cases, in first hour, rapid lowering of need of the reduction of the systolic blood pressure. But once again, must remember in first hour reduce MAF mean arterial pressure up to 25%, and next 2 to 6 hours reduce desired blood pressure will be 160 by 100 mmHg, and when reduced to baseline 24 to 48 hours. Prepared intravenous antihypertensive in hypertensive emergency and aortic dissection, IV labetalol or atenolol, pulmonary edema, IV furosemide bolus, nitroglycerin or nitroprusside given in ICU, acute renal failure, IV labetalol, furosemide, acute coronary syndrome, IV labetalol, esmolol or metoprolol or nitroglycerin, acute ischemic stroke, use IV labetalol, eclampsia, preeclampsia, IV labetalol or hydrolyzine, hypertensive encephalopathy, IV labetalol infusion, subarachnoid hemorrhage, IV labetalol infusion, IV esmolol, intracranial hemorrhage, IV labetalol bolus or infusion. But must remember, never ever reduce blood pressure rapidly. Because why? Because you decrease the perfusion when you reduce quickly blood pressure, then you reduce perfusion to the organ and you face serious complications. Thank you for watching the video. Like and share my video, subscribe my channel. Thank you so much.